Good morning. I am Professor Rajendra Prasad. Currently, I am working as a Director of Medical Education and Head Department of Pulmonary Medicine, ERAS LUCKNOW Medical College, Lucknow. I have been former Director, VALLABH PATEL Chest Institute, Delhi, former Director, Institute of Medical Sciences, SAIFAI, now it is Medical University, and I have been former Professor and Head Department of Pulmonary Medicine at KGMU Medical University, Lucknow. Today, I will discuss with you treatment of tuberculosis in 2021. You have heard my many lectures before also, that tuberculosis is almost curable disease provided adequate treatment is prescribed and it should be taken by the patient. But it is very unfortunate that more than 4 lakh people died with tuberculosis in India last year. If you talk of every day 1200 deaths are occurring due to tuberculosis in our country, and if you convert it, it will come out to be 2 deaths in every 3 minutes. In the first sentence, I said it is almost curable disease, and in the second sentence, I said so many people are dying with tuberculosis. Question arises, why this is happening? And if I have to say in one line, I will say that it's a poor management of already existing TB patient. Today, my focus will be how to treat tuberculosis. Some of the factors are very important for a good outcome in the treatment of tuberculosis. As you know that when we have no treatment before 50s, then probably rest, accommodation, good diet, nursing, climate, sanatorium regimen, and there are many factors which were the main factors for good outcome because there was no drug. Now we have drugs. So even severity of disease is supposed to be relatively unimportant. What is the most important, what I said in my first sentence, adequate treatment, chemotherapy, and it's a regular intake. And as a basic principles, I always talk that in tuberculosis, when there is disease treatment, then there is no single drug therapy. Yes, for prophylaxis, you may someday, otherwise I will take a lecture on the chemoprophylaxis, but when you talk of treatment of tuberculosis, disease itself should be very clear, no single drug therapy. So usually we give multiple drugs, and usually we take most of the drugs in a single dose if it is possible, and drugs should always be prescribed in adequate effective doses and for adequate duration. Now, if any patient of tuberculosis comes to me before 2021, there was 3 type of patients which I used to treat. Treatment of new TB patients, treatment of previously treated TB patients, and treatment of drug resistant. So these were before 2021 guideline. And if you see that for the new patient, what you have got very clear regimen, 4 drug regimen to start with, that is INH, rifampicin, pyrazinamide, ethambutol for initial 2 months, and then followed by 4 months of 3 drug, rifampicin, INH, ethambutol. This is the regimen for India. And we had previously treated patient in which you have used for many years the 5 drug to begin with, including streptomycin, and then 2 months of, and then followed by 1 month of 4 drug, that is INH, rifampicin, pyrazinamide, ethambutol, and then 5 months of 3 drug, that is INH, rifampicin, ethambutol. But you know, this regimen has been abolished by whole world, so it was also abolished by India. So now we can say that you have got only 2 types of treatment of tuberculosis. If I am talking to in year 2021, one is treatment of drug susceptible TB and treatment of drug resistance. As far as drug susceptible TB is concerned, irrespective of whether he is a new case, whether he is a retreatment case, but if he is a drug susceptible, because today it is possible to know the drug susceptibility within 1 or 2 days time with the molecular diagnostics. So, if it is sensitive TB, whether it is a new case, whether it is a retreatment case, but it should be a sensitive tuberculosis, there is only one regimen. Usually what we say that 4 drug to begin with for first 2 months, that is INH, rifampicin, pyrazinamide, ethambutol, and then 3 drugs for subsequent 4 months period, that is INH, rifampicin and ethambutol. This in a continuation phase, 3 drug in India was advised, because as WHO also says that whenever any country the primary INH resistance is high, then those countries can adopt 3 drug in a continuation phase, and that exactly has been done in India with the Indian standards of TB care way back in 2014, but it was given in 2017. So, there is only one regimen today for drug susceptible tuberculosis. Let me repeat, whether it is a new case, whether it is a retreatment case, but it should be drug susceptible TB. Most of the drugs, as you know, we are using in fixed dose combination. Separate drugs are only used when there is a problem of drug intolerance and other issues, then we can use separate, but most of the time it is the fixed dose combinations of the 4 drug and the 3 drugs are available. And weight band, we have divided into 5 weight bands. According to weight bands, these tablets are given in a intensive phase and in a continuation phase. Now, as far as treatment of tuberculosis in extrapulmonary tuberculosis is concerned, treatment of tuberculosis, especially in TBM and serious forms of tuberculosis like spinal tuberculosis with neurological complication, you can prolong instead of 6 months, you may go up to 9 months, even you can go up to 1 year of treatment. That is latest advice. As far as extrapulmonary, if I have to say in one word, in general, extrapulmonary TB receives the same treatment as pulmonary tuberculosis. So, that was story about the drug susceptible tuberculosis. Now, we have come to the drug resistant tuberculosis. You know, we have many types of drug resistant tuberculosis. First, drug resistant tuberculosis will be mono or polydrug resistance, but other than MDR-TB. When there is a resistance to one drug, most common drug is isoniazid. We call it mono isoniazid drug resistant tuberculosis, and it can be 2 drugs, isoniazid and other drugs, but other than rifampicin. Then we have multi-drug resistant TB, you know, it is resistant to INH and rifampicin, both the drugs. And then we have extensively drug resistant XDR-TB. XDR-TB was MDR-TB with resistance to fluoroquinolones and second line injectable. But as you know, the injections are being phased out in the treatment of tuberculosis. So, WHO in 2021 redefined the XDR-TB. Pre-XDR-TB means it is MDR-TB with fluoroquinolone resistance, and XDR-TB means it is MDR-TB and plus resistance to fluoroquinolone, and then at least resistance to at least one additional group A drug, that is bedaquiline or linezolid. That is the latest definition of XDR-TB. WHO has started revising these guidelines 2018, subsequently 19 and 20, and the final guideline came in 2020. Based on this, our government of India has revised the programmatic management of drug resistant TB in 2021. According to this guideline, you have got first drug resistance, you have got the mono or poly drug resistance. In mono and poly drug, mono resistance means there is a resistance to INH. So, naturally INH you cannot use. So, this regimen becomes, instead of isoniazid you use levofloxacin, rifampicin, ethambutol and pyrazinamide, and total duration would be from 6 months to 9 months depending upon the situation. So, the extended directly to 9 months, treatment extension can be done up to 9 months in patients with extensive disease, uncontrolled comorbidity, and then if the smear at the end of 4th month of treatment is positive, and can be extended up to 12 months in CNS tuberculosis and skeletal and miliary tuberculosis. That is the situation of INH mono drug resistant tuberculosis. And the replacement sequence have been worked out, that if suppose levofloxacin cannot be used, then it can be replaced with moxifloxacin, and if the moxifloxacin and or pyrazinamide cannot be used, then you can replace with linezolid, and if linezolid also cannot be given, then you can replace with clofazimine plus cycloserine. If both moxi and Z cannot be used in this particular regimen, then add 2 drugs of the 3, that is linezolid, that is clofazimine and cycloserine. You replace 2 drugs of these 3 drugs, and if R resistance, definitely you have to shift to the multi-drug resistant tuberculosis. That is how replacement is done in isoniazid resistant tuberculosis. Now, you have come to the MDR-TB. Now, today if you are talking of MDR-TB in 2021, we have got 2 regimens, they are 2 distinct regimens. One is a shorter treatment regimen and another is a longer treatment regimen. In shorter treatment regimen, we have got 2 types of regimen again. Initially, you see in 2016 shorter regimen was introduced. It contains injection kanamycin. So, you know shorter regimen in the intensive phase, that is for 4 to 6 months, it consists of moxifloxacin, pyrazinamide, ethambutol, clofazimine and injectable like kanamycin, ethionamide and high dose isoniazid. And in a continuation phase for 5 months, you stop other drugs and you continue with only moxi, pyrazinamide, ethambutol and clofazimine. So, the regimen becomes of 9 to 11 months, and you should understand this is a package of treatment. You cannot change in this any. If you have to change, then probably you have to shift to the longer regimen. And as I said, very recently even the kanamycin was replaced with amikacin, and even injectables as we are moving towards non-injectable treatment. So, we have replaced amikacin with bedaquiline. So, regimen becomes initial 4 to 6 months bedaquiline, in which bedaquiline is given at least for 6 months, and then levofloxacin, clofazimine, pyrazinamide, ethambutol and isoniazid high dose and ethionamide. So, this is 7 drugs in this, And then in the continuation phase, same regimen, levofloxacin, clofazimine, paragenamide and ethambutol. In some 7 states I know in India also has incorporated all oral shorter regimen. Even Indian oral shorter regimen, oral bedaquiline containing MDR regimen, shorter oral regimen containing 9 to 11 months, as we have already discussed with you. There is also there are certain exclusion criteria. You cannot use shorter regimen in every patient. If presence of fluoroquinolone resistance, definitely you have to exclude. Presence of second line injectable resistance is shorter regimen you cannot use. And presence of second line injectable resistance in exclusion for injection containing regimen. Then MDR and rifampicin resistant TB patients with H resistance detected with both CAT-G and INHA, that is also one of the, which means INH is totally ineffective. So, this regimen cannot be used. So, these are the other exclusion criteria. What is children less than 5 years of age, extensive TB disease, severe extrapulmonary forms of tuberculosis, history of exposure to previous treatment with second line medicine in the regimen for more than 1 month, and DST to paragenamide, bedaquiline, clofazimine if available, intolerance to any of the drugs or risk of toxicity from any of the drugs in shorter regimen, then you can even exclude this regimen. And then as I said, we have another regimen, longer regimen, and longer regimen, for that you have to know the lately all the anti-TB drugs used for drug resistant tuberculosis are divided into 3 groups. Group A is levofloxacin or moxi, bedaquiline and linezolid. So, they have been all been revised. Group B is clofazimine, cycloserine, and group C is ethambutol, delamanid, paragenamide, imipenem, celestin or meropenem, amikacin, ethionamide, proethionamide or PAS. This is how now groups are divided. And these you have to understand one thing very clearly. These new division has come based on the individual meta-analysis studies, more than 13,000 patients, and then they have classified these drugs according to their efficacy, according to their mortality rate in the regimen and according to the adverse drug reaction, and they have been classified in A, B, C group. Which drug to use? In a longer oral regimen, as per WHO 2020 recommendations, all 3 group A agents, that is levo, bedaquiline or linezolid, and at least 1 group B agent, that is clofazimine, cycloserine, should be included to ensure that treatment starts with at least 4 agents likely to be effective, and at least 3 agents are included in rest of the treatment if bedaquiline is stopped. So, that is the WHO recommendation. However, in India, the expert concurred that to start with all 5 drugs of group A and B and continue with the 4 drugs in latter part of the regimen. So, instead of 4 and 3, in India we have adopted 4 drug in 5 drug in intensive phase and 4 drug in the continuation group. So, that is the regimen for long, and you can see this is the standard longer oral regimen, which consists of 18 to 20 months of treatment. Bedaquiline, in which 6 months or even longer can be used, levofloxacin, linezolid and clofazimine and cycloserine. This is a one phase regimen, and linezolid, when you stop bedaquiline, dose can be reduced to 300 milligram after 6 to 8 months. and XDR-TB same regimen practically, but duration becomes 20 months. New next TB trial, they are investigating a newer regimen, and for XDR-TB, in which this was published in New England Journal of Medicine, and there they say that BPAL regimen, what you call it as pretomanid and bedaquiline and linezolid. 6 months, and this regimen proven to be very effective, especially in difficult MDR and XDR-TB, and it gives efficacy of around 90%. Last slides, one or two last slides, there are future. What is the future of TB treatment? There are a lot of new drugs are in pipeline, and only thing we had a dream that can you reduce the treatment of less than 6 months for drug sensitive tuberculosis? Yes. Last year this was presented in Union Conference that 8 weeks of rifampicin high dose, isoniazid, pyrazinamide, moxifloxacin, followed by 9 weeks of rifampicin high, isoniazid and moxi, and this is about 16.5 weeks of treatment. So, good news, possibly in future it is going to be used. So, and it could be as good as a 6 months of therapy. And there are many new studies are being done, like GNIX study, when they are trying the different dose schedule of linezolid. TB practical study like compares BPAL with the other regimens, duration being 6 months. What you see is a TB study in which bedaquiline, pretomanid, moxifloxacin, pyrazinamide, duration 6 months again. So, what we are trying, I wrote an editorial in IJCD in last year, and we say, are we moving towards development of universal drug regimen for treatment of tuberculosis? Yes, it has been my dream, and I think it will be going to fulfill in next 4 or 5 years, in which we will be having possibly maybe one regimen. We have reduced from 100 regimen to 33 to 3-4 regimens present, but possibly will go to the universal regimen, which can be used for drug sensitive maybe for 3 months, and for drug resistant maybe for MDR for 6 months and XDR for 9 months. That is what his dream is, what the current scientific thinking is, what should the treatment of tuberculosis in future. So, with these words I have come to end of my presentation, and my concluding thoughts to all of you: drug susceptible TB, whether new or retreatment, should be treated by one regimen. I have already told you. Then all oral mono poly drug regimens have been there for the INH resistance, and then for MDR-TB we have shorter injectable as well as oral regimen, and then we have all oral longer MDR regimen. So, this is only at present we have only these 4 or 5 regimens to treat all types of tuberculosis. With these, I would like to thank and you know that these lectures will be there in the YouTube in times to come, and there are many more lectures on my YouTube. What I would wish that if you can subscribe my channel, then you can get the new information. And then I also have many books in tuberculosis, like manual, clinical tuberculosis, MDR and XDR tuberculosis. They have been all published by JP. You can benefit out of these books. Lately I have written on one drug, which is very crisp book, Adverse Drug Handbook on Adverse Drug Reactions in TB Treatment. With these words, I thank you very much. Thank you very much.